In this PowerPoint, we're going to talk about vascular disorders. Peripheral artery disease is when there is thickening of the artery walls. It usually results in progressive narrowing of the arteries of the upper or lower extremities. The incidence of PAD increases with age, and often it becomes symptomatic between the 6th and 8th decade, so between 60s and 80s. With patients with diabetes, that can occur much earlier. There's an increased prevalence in the U.S. with lower socioeconomic status women and African Americans. It is strongly related to other types of cardiovascular disease and their risk factors because it's just a matter of where that thickening of the arteries is happening. Low levels of public awareness of PAD and its risk factors is common in the U.S., and it's often underdiagnosed and undertreated. So the main cause of PAD is atherosclerosis. And so atherosclerosis is that gradual thickening of the lining resulting from the deposits of cholesterol and lipids and progressive narrowing. Same thing that happens in a heart attack, but here we're just talking about in the peripheral, so in the arms or the legs. Risk factors for PAD include smoking, chronic kidney disease, diabetes, hypertension, high cholesterol, elevated C-reactive protein, and a family history. Additional risk factors are, again, that increased age, that 60 to 80s. There are some gender differences where the homocysteine level is elevated, hyperuricemia, so elevated uric acid in the blood, obesity, sedentary lifestyle, and stress. And clinical symptoms don't occur until the vessels are 60 to 75% blocked. Now, the classic hallmark symptom of PAD is intermittent claudication. This is definitely something you need to know. And so intermittent claudication is when there is ischemic muscle pain. It usually resolves in 10 minutes or less with rest, and it's reproducible. So the patient walks, they get that pain, they rest, it goes away. Atypical leg symptoms are burning, heaviness, pressure, soreness, tightness, and weakness. Some of the other symptoms can be paresthesias, which is that numbness or tingling. Sometimes patients will say it feels like that little tingling, like when your hand's gone to sleep. True peripheral neuropathy, that is more often in patients with diabetes. Severe shooting or burning pain in the extremity. The skin becomes thin, shiny, taut, and hair loss on lower legs. The pedal, popliteal, or femoral pulses are diminished or absent. So if you think about why these symptoms happen, specifically this skin becoming thin, shiny, taut, and hair loss on the legs, it's because there is decreased blood flow to the legs. So if I don't have good blood flow, that's why I'm going to start losing that hair loss on the legs. Other symptoms in the lower extremities are going to be pallor, blanching of the foot. It develops in response to leg elevation. So if we elevate that leg, it already has decreased blood flow. You elevate it, it even gets worse. There's also a thing called reactive hyperemia where you put the foot down and the foot becomes reddened when it's in that dependent position, and that's also known as dependent rubor. That's not what this picture is showing. This picture is showing, this is kind of that dependent rubor. This is showing that critical limb ischemia. So this gangrene here, this is, the person just doesn't have enough blood flow. And as things get worse, the patient goes from pain with walking to pain at rest. So with PAD, it does progress slowly, but the prolonged ischemia, so the lack of that blood flow, leads to the atrophy of the skin, that's that thinning, and underlying muscles. Even minor traumas to the feet can result in delayed wound healing, infection, or even that tissue necrosis on that previous page. Now with PAD, a patient can get arterial or ischemic ulcers, meaning there's just not enough blood flow. That often occurs on the bony prominence of the toes, feet, and lower extremities. Non-healing arterial ulcers and gangrene are the most serious complication, and the patient may end up needing to have an amputation if we can't get the blood flow restored. Of course, they can have uncontrolled pain and severe spreading infection if they're not a candidate for revascularization. So again, remember, we're not getting blood down there, so those wounds are going to be dry because there's not blood. So with PAD, there's some different diagnostic tests. This picture here is showing a Doppler ultrasound where they're doing duplex imaging, where they're actually mapping that blood flow of the veins in the arteries. We need to be assessing our pulses, our dorsalis pedis, and our posterior tib. And of course, anytime we can't palpate it, we need to be making sure there's at least a Doppler pulse. And palpable versus Doppler are not equivalent. Like you have that +2, that +1, Doppler, that's in that order of what's best versus down. We can also do segmental blood pressures, angiography, or MRAs. So one of the best diagnostic tests for PAD is ankle brachial index. It's not useful in patients with diabetes or patients who have calcifications. It's done using a handheld Doppler, and they're going to do that ankle brachial index. It compares the blood pressure measured at the ankle with the blood pressure measured at the arm. And so a low ankle brachial index number can indicate narrowing or blockages of the arteries. So an ankle brachial index ratio of 0.9 or less does equal PAD. If it's between that 0.4 and 0.7, moderate PAD, and if it's less than 0.4, severe PAD. And this next picture just kind of shows that difference, how it's checking this Doppler right here, and then it's checking it here, and then that's how they're going to do that math to do it. I'm not going to have you do a math to figure that out. I just wanted to kind of show you how that looked. So one of the things is going to be getting the patient to reduce their risk factors. And so quitting smoking, trying to maintain that A1C at least at 6%, as close to that as possible. And we'll talk more about that when we get to diabetes. Aggressive lipid management, dietary and drug therapy, hypertension management, and then lifestyle changes, that sodium, and then that DASH diet that we talked about with the hypertension. And the DASH stands for Dietary Approaches to Stop Hypertension. And I just added a little picture in here to show the types of things we want to encourage them to eat versus the things we want them to limit or try to avoid. So some of the care for somebody with PAD, medications could be like an ACE inhibitor like Ramipril. That helps to reduce the PAD symptoms. Antiplatelet medications such as aspirin or clopidogrel. Pentoxifylline, also known as Trentil, actually increases the red blood cells' flexibility. It also helps to decrease the viscosity of the blood by decreasing the erythrocyte aggregation. And then silostazol, Pladol, is also similar to like an antiplatelet therapy. Exercise therapy is very important. We want these patients to be increasing their activity slowly. Nutritional therapy, try to get that BMI less than 25. And then, of course, there are some other complementary and alternative therapies too. So once PAD has gotten really bad, that's when somebody's going to be considered to have critical limb ischemia. And ideally, we're going to do revascularization therapy via bypass surgery. Again, same thing with the heart. We can bypass the blockages. We can do that in our legs too. If surgery is not feasible, then we can do a percutaneous transluminal angioplasty, or again, those medications. So some of the care for somebody with critical limb ischemia is going to be protecting it from trauma, helping to decrease that ischemia pain, preventing and controlling infections, improving perfusion. And we're going to teach them to carefully inspect and cleanse their feet. We're going to encourage them to lubricate their feet, meaning lotions, but we want to make sure they know not to put lotions between the toes, and they should never soak their feet to prevent that skin maceration. You know, when your foot or hands, they turn that white and kind of pruny looking, that's considered maceration. If somebody does have an ulcer, we want to keep that affected foot clean and dry. Cover any ulcers with dry, sterile dressings to keep it clean. Deep ulcers might be treated with wound care products, but healing is unlikely because without the blood flow, it's not going to heal. And the patient may need systemic antibiotics. We want to teach the patients to pick footwear that's going to be protective, soft, and is not squishing their feet in any ways. We want to also teach them to avoid extremes of heat and cold and to keep the heels free of pressure. So think about when we have the bed and we offload the heels with pillows. This statistic is a little sad that most patients with critical limb ischemia will die within 5 years. And the reason for that is because this atherosclerosis that they have in the legs is probably not the only part of their body that's affected by that. So there's a couple different ways that we can treat blockages in the legs. One is through interventional radiology, where we're doing that percutaneous transluminal angioplasty. And in here, I put a picture of where they've done that stent, where they're doing that, and they're putting a stent in here. So this is an example of what a stent would look like. Arthrectomy, where they're actually just taking out some of that atherosclerosis, or cryoplasty, which is where they do that dilation of the balloon, but they also cool the vessel walls. And if those aren't options, then the patient may need to have surgery, where they actually do bypass grafting of that. They might use synthetic grafts versus the autogenous vein, where they're using their own veins, endarterectomies, or amputation. So this is just showing you bypass grafting. So this yellow part here would be the part that has the blockages. And here, this blue part here is where they're using their native vein and they're going around that. So they're coming up here and then they're coming down here and they're actually just bypassing it. Same thing they do in the heart. Now this one is where they're going from here down further, and because it's so much longer, finding a native vein, they actually have to use a synthetic graft for that instead. So of course, some of the nursing diagnoses that we would see with this would be ineffective tissue perfusion peripheral, activity intolerance, chronic pain, or ineffective health management. Of course, our goals are going to be to improve that tissue perfusion to adequate, relief of pain, increased exercise tolerance. We're hoping that they end up with intact, healthy skin, and they're able to have appropriate knowledge for disease and treatment plan. So when we have somebody who has that lower extremity PAD, we want to try and identify those risk factors and then teach them about modification. We're going to want to make sure that we're doing those neurovascular assessments anytime there are any procedures. So that's the color, temperature, capillary refill, presence of peripheral pulses, and sensation and movement. And then we're always going to be assessing for palpable pulses versus Doppler pulses. And this should really have the 6 Ps. The one that it's missing is that poikothermia, basically whether or not it's cool or not. And then, of course, making sure that we are addressing their pain needs. Now, when somebody has their angioplasty, their peripheral, things that we're going to be watching for is you look at this bruise and you think, oh, there's no way. Actually, there is a way. And so you can see the little stick right here where they actually had that stick. Anytime, they'll usually have a little 2x2 here and a tegaderm over that 2x2. You're literally going to take your hand and palpate around that, because you may not always have a nice big bruise to tell you there's a problem. You might get a hematoma. So we're always assessing for bleeding, hematoma, any thrombosis, which could cause decreased circulation to the legs, embolization, or compartment syndrome. So just because they might have that stent doesn't mean that it can't occlude. So we're going to be watching for a dramatic increase in pain, loss of previously found palpable pulses, extremity pallor or cyanosis, numbness and tingling, cold extremities. Tells us that potentially that graft or stent has reoccluded. And so those would need to be reported to the healthcare provider immediately. Make sure that you're not putting the patient in a knee flex position. So think about when you put somebody in high Fowlers, how that knee kind of flexes up. We don't want that knee to flex up like that. And of course, with all patients, we're going to want to help them turn and reposition frequently. And post-op day 1, we're going to be getting them out of bed several times. So while we're going to be encouraging them to be out of bed, we don't want them doing prolonged sitting. That leg dependency increases pain and edema, increase the risk for DVTs, can put some stress on those suture lines, and if they do get edema, we will elevate the legs normally. Graduated compression stockings may be used to control leg edema, but that is only if they have good pulses. And of course, we're going to be assessing for surgical site infection. Ambulatory care or outpatient, it's going to be a lot of the same. Assessing for those risk factors, health promotion, smoking cessation, long-term antiplatelet therapy, either with aspirin or the clopidogrel, teaching them the exercise training, foot care, nail care, and so we want to make sure that they're aware of all those things. Now, patients can also get an acute arterial ischemic, where there's a sudden interruption in that arterial blood supply to a tissue, organ, or an extremity. If untreated, they can have tissue death, and this either can be from embolization, thrombosis, or trauma. So a thrombus from the heart can be one of the big causes of acute arterial occlusion. Some of the causes that could cause that are infective endocarditis, mitral valve disease, AFib, cardiomyopathies, or a prosthetic heart valve. Non-cardiac sources of emboli would be aneurysm, ulcerated atherosclerosis plaque, where it's just kind of come off by itself, recent endovascular procedure, or a venous thrombi. So again, here's those 6 P's I was talking about: the pain, pallor, pulselessness, paresthesias, paralysis, or poikilothermy. I see it so much better when I can look at that. So without intervention for an acute arterial ischemic disorder, ischemia can progress to tissue necrosis and gangrene in just a few hours. That's why we're going to notify the healthcare provider. Paralysis is a late sign of acute arterial ischemia and signals death of the nerve supplies. Foot drop can also occur, and nerve tissue is extremely sensitive to hypoxia, so limb paralysis and ischemic neuropathy can persist even after there's been revascularization. So once we've identified arterial ischemic disorders, anticoagulation therapy might start, and that might be IV heparin, very different than subcutaneous heparin. And so the big thing to know about heparin is that heparin does not break down a clot. It simply prevents the thrombi from getting bigger and keeps there being more embolization. We would expect them to have long-term anticoagulation with warfarin, and we'll talk about the heparin-warfarin bridge a little bit later on. We want to try to restore that blood flow again, either through a surgical thrombectomy. They could have a percutaneous catheter thrombotic therapy where they're actually putting that alteplase right there. They can actually percutaneously try to take that clot out or bypass it.